Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. Welcome everyone back to another episode. Today I'm with Dr. Jake Stucki. He's an oral and maxillofacial surgeon practicing in Denver, Colorado. Jake, thank you for joining us on the podcast.
Yep, glad to be here. Now we can finally officially say that. Yeah, you forgot to mention board certified.
That's right. Board certified. Congrats, man. So happy for you.
Yes, thank
A
you.
long, arduous process.
Now we can get back to the important stuff, which is podcasting and actually doing oral surgery.
Let's go.
Not just studying about oral surgery.
Yes. I'm sure many recently graduated residents can relate to you.
Yeah.
Sure. Well, good. So today we wanted to talk about, kind of a specific dental alveolar scenario, which is kind of dealing with displaced root tips. This is a little more of a technical topic. Those who have taken out several teeth over the years, I think could find some value in this. Hopefully those who are just getting started in their extracting oral surgery career don't turn it off, because there's, I think, some good tricks and tips we'll talk about. But maybe you could start us off with what are some scenarios where you're kind of on red alert for potential root tips to be displaced into places you don't want them to go.
Yeah, so I mean, I think just when you think about root tips in general, it's like, you don't want to have them to begin with, right? You want to just elevate a tooth, take out the tooth, got the whole thing, move on with your life. Like it's just so much easier.
Yeah.
I think when you're taking out teeth with like long spindly roots, maybe teeth that have dilacerations, teeth that are root canal treated, maybe older patients, people with, harder bone, I guess, like you've taken out like some wisdom teeth, people over 30 years old, those kind of scenarios where you really have to elevate a tooth and try to change the angle of it maybe before it'll come out properly, impact the teeth, stuff like that are scenarios where I've seen more root tips just in general. And getting a root tip is always, you got to pay close attention. And I think we've talked about this in a previous podcast, because as you're elevating, sometimes you'll feel like a crack, hear a crack, or even maybe as you're using your forceps, tooth's about to come out and you hear or feel something. And so you take out the tooth and you look at that. You either can immediately see it, sometimes it's huge, sometimes it's hard to tell it's even in there. And you look at the tip of that root and you can tell it's sharp, it's shiny, and you're like, okay, let's go look and see what's going on here. And so I think that's a critical time, because at that point you gotta attempt to start retrieving that root tip. I guess you can make the decision whether you need to. Most of the time, the answer is, we try to retrieve it. And then it gets to that question you asked, which is, what should we be looking out for so we don't displace that root tip and cause it even more of an issue? So I think, teeth around the sinus, teeth with roots that are sticking way high up into the sinus, a lot of like pneumatization. Maybe teeth that are like mandibular third molars are really lingual, they're like sticking way off towards the lingual, or maybe just deeply impacted, real deep down in there by the nerve, are some of those situations where when you're working with that root tip, you might displace it more.
For sure. Yeah, I think of, in my mind, I'm thinking the 25 plus year old wisdom tooth patient. Okay, so recently I had a patient who had, I think, maybe 27-year-old female. I'm extracting, a number 32, crown is buccal, roots lingual, and just hard bone, like almost no periodontal ligament there. And, tooth is just brittle, it's cracking, getting down to these roots or sectioning the roots. And then I got maybe 3 millimeter piece of the root here, and, create a little bit of a buccal space by the root to get my small straight elevator in there. Elevate, and then kind of hear the crack, and then it's one of those oh crap moments where it cracks and your elevator kind of slips a little bit, and you can feel that you just lost resistance, and
Mm,
now the basically the very, very paper thin bone, which was probably ankylosed to the root or just rock hard, gives way, and now this root tip is has slipped into this like soft tissue space. And so that kind of, I think to myself, how do you avoid that in the first place? One is when you're dealing with these patients that are whatever 20, 25 plus, is I think it's more creating more space and elevating carefully so as not to like just crank and push it lingual. You're kind of more trying to pull it up with just really care. So it's almost like you're getting under the root and trying to flip it up as opposed to
mm,
get buckle. Anyways, so just being careful because with us teenager, you got flexible bone, flexible roots, everything's much more flexible, and maybe you can put a little more pressure, and that root will um, kind of go where you want it to go, which is out towards the oral cavity. So what would you do in that scenario? Now you've displaced this root lingual and it's kind of floating there, and you maybe get your elevator, you're trying to grab it, but it's just now it's slipping all over. There's no resistance to really grab the root. You maybe get your hemostat. It's too big. Nothing can grab onto it. Where do you go from there?
yeah, so I think the first thing, like when I'm having a situation like that, I just let my assistants know, to be careful. Okay, wait, let's slow down. Let's take a look here. This area is loose. We gotta be very gentle. Because last thing I want is my assistant trying to be helpful, but like stick the suction right and push something deeper, or maybe make things harder to see.
Mhm.
Which is like, unintentional, but it can happen. So usually I would take the suction myself and just very, very carefully suction over where that root tip is or was, and try to see if I can identify it. Do I see what's moving? Is the suction kind of grabbing onto it and gently kind of pulling it towards me? A lot of times it's kind of stuck like on the other side of like a hole, or it's stuck on some soft tissue, and the suction is really just not strong enough to get it. But I like to start with that just to see if I can see where it is, and sometimes it can come out with the suction. But that's my first step, is just kind of reassess the situation, see if I can identify where the entire root is. If not, get more visualization. For a lower third molar, I would maybe put my finger on that lingual aspect of the ridge and see if I can feel it from that aspect. Because if it's been pushed, through that, presumably that lingual surface, it might be palpable. And if I could get below it and to prevent it from going deeper, that'd be helpful. And then, kind of just depending on how that root was responding, potentially make that hole a little bit bigger, slightly bit larger to be able to retrieve it back through that space versus maybe just manual palpation and getting it through. Now, if I couldn't do any of those things and the root truly was just displaced and disappeared, I would try my best to irrigate, clean, and then close patient on antibiotics, get some imaging, kind of make next steps based on where it's at and what I see.
Yeah. Yeah, I like that. The same. Yeah, I start going for the suction first, more to kind of tease it out towards the socket where you can see it. But I think, well, let's say you tease it and you get into a place, I can see that lingual root now. I can on the lingual there in the soft tissue, and then tendency is try to get your elevator in there. But it just you can't grab it. So like you're saying, you need to create resistance. It's almost like you need to create what the buckle or the lingual bone was doing for you, which was giving you
Hmm.
resistance and holding it. And so you can do that a number of ways. I think maybe the sweetheart someone could go to, a Selden, a periosteal. I have just found more success, like you were saying, oftentimes with my finger. This in this case, this root tip that I was dealing with got like slipped so far lingual, and I think assistant was kind of poking at it, trying to get it with a suction, and it just slipped under the mylohyoid ridge, and then it just totally disappeared. And so that's when you really start sweating, because once it gets under, it kind of trapped into that ridge. It's very hard to get back out. I mean, it took me a few minutes of struggling, and ultimately, luckily, the patient was sedated, but I basically had to get my finger kind of wrap it down under the ridge, feel the root tip, and like with quite a bit of force, really like pull it up with my finger and pressing to try to slip it over the ridge back into the socket. And then once it's in the socket, holding pressure. with the finger and then grabbing the instrument like a, in my case, small straight and like working it up slowly and then assistant grabbing it with the suction. But I mean, it was like, I mean, been extracting teeth for, 15 plus years. And I mean, it really surprised me again, like, because this doesn't happen often. This is once every few years, just how much pressure it takes and resistance you have to provide for that root to pop back in sometimes. Yeah. Any other tips you've got on retrieving these, lingual roots?
No, I think that's the main thing. I mean, you obviously don't want to cause more damage, so like if you're gonna open that hole up, maybe where it disappeared to see, you got to be very careful. You don't want to injure the lingual nerve, cause
Yep,
more issues, um,
sure.
and make things worse, bleeding potentially, those kind of things. So yeah, I think it's just a matter of trying to, diagnose where it's at, what happened, and then taking those steps like you did to try to retrieve it if possible.
Yeah, the first time this happened to me in a residency, it was scary, of course, and Miss disappears, what's going on. So we stop, we take the patient to the CBCT, take a CBCT. Yep, sure enough, the root's just floating down there under the Mile High
Hmm.
Bridge. Okay, well, we're gonna get to it. And sometimes, you can leave these in place. And I've heard, people doing that with some success. If you can't retrieve it at all,
Just
sometimes
allow it to fibrose, and as long as it doesn't get infected.
yeah, kind of, yeah, set expectations, can fibrose.
Hmm.
But yeah, like you're saying, do no harm. You certainly don't want to retrieve a root at the sacrifice of an important structure like the lingual nerve or lingual gland or something, or a solid submandibular gland. I mean, you can get pretty deep in there in these tiny holes and just be damaging things. So you got to be super.
I mean, I guess another thing just to consider, you could theoretically open a lingual flap. Again, considering all just the local anatomy and making sure you're not injuring the nerve or other structures around there, but just depending on where that root is,
Yeah.
just to get better visualization access to it.
Yep. Yeah, we use the McKesson suction tip, like a 4 to 5 millimeter aperture. Those are pretty good, I feel like, to get down there because you really got to have a good strong suction. I mean, this goes back to making sure you got great suction and a good suction tip because that can be one of your most valuable tools is
Hmm.
pulling it with a suction as opposed to like, pushing it with a tool. But
Yeah, absolutely. Another situation that I've kind of mentioned earlier that I've run into a fair amount of times is the similar situation with the third molar, but on the maxillary.
yeah.
The classic, displaced maxillary tooth. Hopefully, people aren't running into that frequently where it gets displaced posterior, into like the, you know, temporal. Yeah, exactly, infratemporal space. But more commonly, in my experience, is it wants to get displaced into the sinus. So
Mhm.
those teeth that are high up and they,
Sure.
for whatever reason, are just very, very close to the sinus. Maybe they're really palatal. I feel like sometimes that can make it tough to elevate out buccal. Rather than like the tooth that's nice and buccal, you just put a little force and it just goes right buccal. Whereas the tooth that's really palatal and high, you start putting force on it, and if you're not getting around it, it could just push it. It's basically just a direct force, either posterior or superior, and it just goes wherever there's least resistance. And
Mhm.
that one is more just the whole tooth, not necessarily like a root tip. Although you definitely can have the same situation with a root tip up there.
Yeah.
But with that, what I found is like usually it doesn't just like push, boom, it's gone. It's like you push and you start to notice it's like going in that direction where you don't want it to go, and that's where you gonna have that situation where you stop. Get your flap wide open, get your Minnesota behind it, tell your system to be very careful, not to push it. I've had a couple different success doing a couple different things. Maybe make us like very gently make a purchase on a place where you can push and it's not going to be moving, and then use a cog 12B or some sort of like a root tip pick to engage that and pull it towards you. Sometimes something as simple as using a number nine to kind of wedge it in there. Kind of what you were saying, how you need to create a little resistance. So if you can gently get a number nine into a place where it's more apical to it and kind of create that resistance coming towards you rather than just pushing on the tooth, you can get that moving in the right direction. Or like a POTS, something like that. You just have to be careful to get around and use that right vector before you start putting force on that tooth. Just being careful. Now, if the tooth does get displaced on the maxillary, you know, you essentially have to open it up and take a look at that sinus. There's different techniques, to get a tooth out of the sinus. What are the kind of things that you would typically go to in that situation?
Yeah, so if it's root or tooth that has totally displaced up in the sinus, it's my first step is irrigate, suction, and try to see the tooth through the socket. If I can at all, then almost, very commonly, if not always, I have to enlarge in the socket there to see it better. Because what happens, I think, oftentimes is like big tooth or root, bulbous root gets up in there, and then once it's in the sinus, it rotates and spins in a direction that you can't now pull it back through the same hole. It's
Mm,
like the operation game, is now the orientation of that tooth fragment or tooth is in a position that it just won't fit through the hole that it went through because now it turned in a different position. So usually it's okay, I see it, but it's too big to come back through. And so you got to open it just very gently with a Fisher burr, a round burr, and then it's teasing it back through. That's usually what I do with success. But again, if you can't see it at all or it's just not coming through there, then I mean a Caldwell Luck is kind of where I would go next. What would you do?
yeah, I do the same thing. And then I think just a note is like, depending on the situation, I think that to try to avoid, pushing a tooth up there with a lot of force, I don't really hesitate to go to the drill. You have to,
Mhm.
with a sedation, you have to realize, it's definitely different when you're irrigating up. You really have to have a good throat pack. You really got to suction right. Make sure the fluid doesn't get back into the pharynx there. But assuming you're doing those things properly, you can do a little bit of a trough, maybe put a purchase on that tooth while it's totally solid, and just avoid the whole situation completely by making it so that force the path of least resistance is out, buckle by just removing a little bit of that stubborn bone and getting a nice purchase on there. If you really need to, section those teeth, I don't think there's anything wrong with that. I've done that plenty of times and it's been really helpful to avoid some of those really tricky situations. And then it just makes things so much easier. Is that something you regularly do?
What do you mean?
Removing bone with like either a hand piece or
Yeah.
Roger, or either sectioning an upper third or placing a purchase, something like that. Some adjunct rather than just strict elevation.
Yeah, I think I'm at least according to assistants I've worked with, I'm way quicker to go to a handpiece, like pretty fast to go and remove buccal bone. Not a ton, but enough to really see what's going on and get a purchase. Whereas I think a lot of surgeons are really hesitant maybe to do that. Maybe I don't know if they don't want to, they're worried about catching the flap or whatever it may be. But I really want to paint around it, kind of get into that mesial space and create
Hmm.
room and see what I'm doing. Especially that really distal-angulated tooth on a maybe an older patient, like well, when I say older for wisdom tooth, like 25 years plus. You got it really distal-angulated, roots halfway in the sinus, older, brittler bone. And if you're not careful, just so quickly, if you're just putting um, distal, buccal distal pressure, that tooth will pop right up in the sinus. So it's certainly to me removing enough bone to see the orientation of the tooth and then like elevating it carefully and trying to get up, like you're saying, at a more superior mesial vector, and it's more like kind of downward pressure as opposed to just straight distal pressure. It's
Yeah.
also trying to avoid cracking the tuberosity off and just making a much more traumatic extraction.
Yeah, absolutely.
I would say too, another pro tip with let's say the tooth is displaced or the root's displaced is patient positioning. I think too often it's gone and the patient's totally back flat and you're trying to I can't see it, I'm suctioning and where is this dang tooth? And you kind of lose track of the fact that you're fighting gravity and that tooth is way up there on the posterior wall. So unfortunately, you have to kind of sit them up more and let gravity kind of pull it down, which means that you're going to
You're bending over.
crank your neck and your
Yeah.
back to see it. But sometimes you got to do what you got to do to get that tooth, with gravity helping you as opposed to hurting you.
Yeah, 100%.
So it's that, and then let's say you got it, and it's like right there, you can feel it. You got your suction, you're teasing it. Um, and there's just you don't have that counter pressure you need. I think it's large enough hole, good patient position, gravity's helping you, And it's really more for me it's suction work and teasing it with a suction as opposed to getting an elevator and hoping to bring it back down with an elevator. Sometimes it's a periosteal up on the palatal aspect and then suction and kind of almost like chopsticks where it's like periosteals pressing on the palate once you have it, and then the suction's pulling at buccal. I mean, everyone I'm sure has their own technique, but what have you found to be successful?
Yeah, I mean, just the same principles. I just can't stress. You got to be able to see it, and sometimes it's just so hard. Like the reason you got into that situation is because it was high up there and pretty far back.
Yeah.
You know, so all the stuff you've talked about before, you know, maybe close the patient's mouth just a little bit, use the small bite block, have your assistant push their jaw towards the side that you're working
Hmm.
on to get the coronoid out of the way, you know, really make
Extend
sure
your
that
distal
flap
release.
exactly straight down the back of the tuberosity. Probably want to release the papilla at least, you know, between the first and second molar. And then just make sure you can see everything. And then from there it's a lot easier to decide because like if it's getting stuck like you said and you need to open it up, you can see well enough to make that decision.
Yeah. And you've been working at this for 15, 20 minutes, not getting it. I would not hesitate to, do a Caldwell Luck,
Hmm.
open it up, see it, irrigate it really well, retrieve it, resuture it. I mean, and it really doesn't have to be a huge, um, Caldwell Luck opening. There's ways to do it fairly small and less, not very traumatic, but yeah. So just knowing the steps and having that plan in place, I think can just save you. Because what happens, I think, is too much like you get into panic mode and you're kind of making bad decisions because you're just freaking out, right? And
Hmm.
you're upset to the assistant, you're yelling at them, and you're, trying to
And you
blame.
know they can't see. You can barely see.
Yeah. So it's taking a deep breath. Sometimes too, pro tip is just for me is just taking a break. I gotta be like, okay, I'm cranking my neck, I'm sweating, I'm getting a little worked up. It's not for me, it's never been a problem to say, okay, let's just let the patient sit there for a minute. I'm gonna whatever, walk around for a few minutes, go see another patient for a few minutes, come back. Now I'm in a better headspace. Um, Especially, if and maybe you talk to your assistants about this ahead of time. Hey, if I ever get to this point and I'm yelling at people and like, just can you remind me to take a break and stuff like that? 'Cause these things can be pretty stressful for sure, and you don't want to be, destroying more bone, getting into, doing dumb things with a burr and wrapping up a flap just because you're getting frustrated.
Right,
So
exactly. And then
careful.
the only other thing I was thinking of too is you know, when you have a fairly large hole into the sinus in a third molar, maxillary third molar area, you know, the conventional wisdom like textbook is like, hey, if you have a hole bigger than maybe, you know, 6 millimeters, something like that, you should do maybe advance the tissue. If it's a really big hole, do buckle fat pad advancement. What's your go-to? Let's say you have this scenario, you get out the root, it's a pretty big hole, you know, that you've had to make. How do you typically close that in the scenario?
I almost always just extend my distal release, free up buckle fat pad, pull it forward, fill the hole. If it's a significant hole, and then like you're talking about, kind of really score the tissue and really try to get primary closure. Maybe I'm using a little more long-lasting suture like Vicryl or something to that effect, or Cytoplast, removing it later. But yeah, trying to close it like as best I can, primarily watertight, ideally
Hmm.
with something there. What would you do?
Yeah, I mean, same thing. One of the things I've noticed is like if you can, first of all, if it was complete bony impacted and this tissue was totally intact to begin with, it's usually not too hard to get that closed again. You know what I mean? So like
Yeah.
it, you know, this isn't textbook, but something that I've talked with other surgeons about, and they've done this, and I've done this and seen success is like specifically for a wisdom tooth that was complete bony, you can very easily get total closure. You know, it might be something to consider depending on, you know, how big that hole is. If it's huge, you might not have any options, but you might be able to just primarily close that tissue, get watertight closure, and then save that buccal fat pad potentially, you know, for the future in case you need it. Because so many of those, you know, you got gravity on your side. Yeah, this tissue kind of naturally is just laying down. The tongue's not up there moving things around. And if you can keep the patient on sinus precautions, it seems like most of the time those will heal up on their own.
Yeah.
Assuming you can close it like that. You didn't tear up the flap and have a big hole there.
Hmm.
Which goes back to, what we were talking about earlier. But that's just something to consider. If you can get nice, good closure, in some situations you may not need the buccal fat pad, and then kind of just have the discretion to use it when you feel like it's really big. Now, if you have that same situation, like you displace maybe like a number 14 and you have a huge hole and you had to do a Caldwell Duck and all that stuff, that's a little bit of a different story because you have that soft tissue deficit where the tooth used to be, and the hole's probably a lot more likely to stay open compared to
Hmm.
the third molar that's high up there.
Yeah. Yeah. I mean, I think what we just talked about is like 95% of all displaced roots is like sinus or lingual soft tissue for the third molars. Infratemporal fossa can happen. I feel like Um, when it really gets infratemporal fossa in like a space that's like way far away, and distal that you can't retrieve it, that's usually a result of like what happened immediately after the tooth, like you notice it got displaced. That's when you need to stop. Whoa, let's stop here. Let's not be putting adverse pressure. Let's be very careful and gentle. Because if you immediately stop and you're like being gentle, careful, looking, um, so, palpating gently, maybe with your finger, distal. Like I can almost always avoid having this tooth go way into the infratemporal fossa and retrieve it intraorally. But the few times I've seen someone get it way distal where you can't get it, and you have to let it fibrose for weeks and go in the operating room and do all this CT navigation to retrieve it. It seems like the story usually was like just being way too aggressive and trying to chase something, pushing it further, further, further because you weren't being careful enough. I don't know what your experience is with that.
Yeah, luckily I haven't had that, ever happen. But if from the people that I do know who that's happened to, it's just if you keep your Minnesota behind distal to that tooth, essentially at all times, it's going to be, path of least resistance. It's not going to want to go that way. It's going to
Yeah,
want to go into the sinus, out the buccal. And so that's one of the main things that was hammered into me as a resident is make sure your flap's big enough to get your Minnesota in that back place to protect her.
yeah. I think this goes hand in hand, like displaced roots and teeth can go hand in hand. There's a very similar discussion with implants, right? An implant can
Hmm.
easily. A periodontist recently, he said he was going to uncover a number three implant. And, this is 5 months after he placed it. He goes to uncover it. He said he's just, finger tightening, trying to remove or tighten. I can't remember the healing abutment, and then boop, just gone. It goes up in the sinus and gone. We later he referred it to me and we did a call to luck and retrieved it. The other thing I was thinking of just a few weeks ago, I was doing an implant on it. I think it was a number 30, and it was an older woman who was on a Ozempic or GLP-2 inhibitor, super porous bone. And while I'm kind of tightening the implant, all of a sudden it just drops into this marrow space, like a big, huge marrow space in the body of the mandible, and then it rotates sideways, like completely
Holy.
completely perpendicular to the entry point. So I ended up having to open the hole, the aperture more, and then remove it, and then say no, we're going to do an implant and graft it and PRF and all this stuff. But I think, just a side note, I think we're seeing that more with some of these medications with, I don't know, maybe poor diet, osteoporosis. I think we're seeing more potential for things like that. Just really soft, porous bone, big open spaces in the marrow, just unhealthier people in general. So I think similar principles as you're trying to,
Hmm.
retrieve it, establish some type of counter pressure and slowly tease it out. Implants are, I think, oftentimes trickier because they're just so much more like grippier, right? They have all these like projections on the implant that's like really
Stopping
making
it from coming back out.
yes. And so that's when probably it's nearly impossible, like one that goes in the sinus, to get it back to the hole. You almost always have to call the luck and get it out that way.
And the way you described that implant disappearing, it sounded like, those specialized drywall screws that you place in, and the second it goes in, boop, turns sideways. It's like, yeah, it's not coming out.
Exactly, man. Yeah, that will That'll make you sweat a little bit.
Absolutely. So then I guess the next, conversation there, I'm sure there's lots of other very, interesting places roots can get displaced into the IAN and all sorts of other places. But um, the question is like when do you just leave a root tip? You know what I mean? Like when do you avoid pushing on it too much when it's in a place where you're at risk for doing these kind of things. So how I know as surgeons, as dentists, we hate to just leave root tips. I've definitely met people who are like, "Oh, I never leave a root tip. Never. I don't care where it is, what it's doing, what it looks like, it's coming out." And like, maybe everyone can relate to that to like at least a certain extent. You want to get that thing out. You don't want to take an X-ray later and there's a root tip, and then they're telling everyone for the rest of their life, "I had this oral surgeon and he left this root tip there." You know what I mean? There's the risk of infection. There's the risk of it moving around. There's the risk of it causing, those are the main two ones. But
Yeah.
kind of what's your decision making there when it comes to if you did need to leave a root tip, when would that be?
Yeah, I think all too often we are have the mindset of the army commander, and the motto is no man left behind. It's like
Yeah.
to get my man out of the platoon in the middle of the night, and we gotta jeopardize the team. And so you
And
just
that's
get,
the root tip.
sometimes you do more damage than if you were just to leave these little root tips there. I think so for me, it's like less than 3 millimeters. In it's non-mobile. Let's say it's like 15 or 16 root tip, tiny little piece of root up there. It's wedged in there. It's like ankylose. It's not moving. There's no chance we'd ever place an implant there. I mean, that's where
Hmm.
I'm much more likely to just to say, hey, let's not, make a situation worse by trying to create a big hole, potential sinus exposure just to get out these root tips. Because I do think
Hmm.
the majority of those are gonna just heal up, bone will form, and they'll never bother them. So I really don't think you have to remove every single root tip. You got to kind of think about it. What are the repercussions here? Look at it, assess it. Is it small? Is it not moving? Is it all that type of stuff. What
Yeah,
what would you say
exactly.
is for you?
Can we pause for 2 seconds?
Yeah.
Yeah, so I mean, I agree with those things. I think like classically the textbook answer, if it has an infection, you got to take it out. Like periapical relucency, you probably should make sure you get that out. If it's mobile, like let's say you elevated the tooth really well, things are coming out, then it cracks, and you look in there and that tooth, the root tip's moving around. It's just like kind of maybe you got a hook on it or whatever it is, and it doesn't want to come out, but it's mobile. Probably should get that out. And then, yeah, if it's larger, I try to make sure it's like maybe 1 or 2 millimeters if I were to have to leave it. But if it's bigger than that, you probably should, trough around that, get some traction and get it out. Yeah, I don't know if there's any other very specific situations I'm thinking of, but if it
Maybe
doesn't
if
meet any of those
it's
criteria, yeah, go
maybe
ahead.
if it's dilacerated, hooked under the nerve, the IAN, um, potentially there. And if it's not mobile, most of those you could tease out, but that's
Right.
you're thinking of coronectomies and all that type of stuff.
Yeah, so normally that if you did decide to leave a root, I put them on antibiotics, flush it out really good, primary closure, talk to the patient, hey, there's a very small piece of root, this is what I saw, didn't want to cause injury to whatever structure was in the area. I want to monitor you, just make sure this heals up, put you on antibiotics. The vast majority of patients, will do really well, and that
Yeah.
root tip, will just be healed in by bone. But there's a chance it could have an infection, and we will treat it if it does. And
Hmm.
what I saw in residency was the ones that do end up ever having issues, maybe they'll come back like 2 weeks later, it's swollen, it really hurts. Maybe they didn't even know that a root tip was left behind and they just have an
Yeah.
infection. You open up the site and the root tip's just floating there. It's like
Yeah.
on a golden platter of granulation tissue because it's like been
Yep.
so irritating that the body is trying to like deal with it. And so it's almost like a sliver
Exfoliate
gets
it.
loosened
Yeah.
up. Yeah. And then you take it out, clean it out, and kind of go from there. But I think, yeah, just communicating with the patient. And then most of the time, from what I've seen, the rare times where we've had to leave them, they do just fine.
Yeah. Totally agree. All right. Well, hopefully this has been a good topic. It's one of those things that can definitely cause stress. I think a lot of these things you can avoid if you're kind of more aware of the scenarios where that can happen, and just kind of taking your time. But when it does happen, I think our takeaways are point of resistance, good clear visualization, usually kind of opening up the space more to see it. I mean, really, I think it's just using. So Gordon Christensen is this dentist, a famous dentist who gave all these courses, and his our dad is a general dentist, and so he loved Gordon Christensen's sayings. He had all these refrains, but one of his refrains was, sometimes the best tool you got is your own finger. And I think he was saying that in regards to like if you did a composite on a tooth,
Yes.
an occlusal, instead of like carving it out nice, you just stick your finger and like flatten it there with your finger. That's what he was referring to. But the same applies when, for me, you're dealing with a lingually displaced mandibular root, is trying to get your finger down there and really create pressure and pull it back up, which we usually don't like to do because we're trained to use instruments and things like that. But that's what's worked for me. So you know, your finger, taking time, sometimes taking a break, irrigating, suction, having all the right tools you need. Like you said, a pro tip is talking with your assistants, letting them know what's going on so they're not worsening the
Hmm.
situation by jabbing a suction in there or something that's displacing it further. These are all critical pro tips.
Yeah, nothing makes an assistant happier than getting the tooth out before you if they can suction it.
That's right. They're gonna
And
go
you're like,
for it.
now is not the time. Please don't do that. I'm
Yes.
having trouble getting it out myself.
Exactly, man. Well, good. Thank you for running through this stuff. I think it's a good topic. It's very technical, dental alveolar, but hopefully this helps some people out there. If there's listeners who have other pro tips, email them, text them to me. I'll share them on our next episode. I'm always looking to learn, so anything you guys can help out would be great with this topic. Any other parting words of advice?
No, that was great. Thanks for taking the time. Glad to be back.
Yes, good talking to you. Thanks so much. Have a good
Yeah,
night.
you too. Bye bye.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and I've been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.